So today's talk, I'll primarily focus on a small section of hypertrophic cardiomyopathy. This could be a whole conference when we talk about this. And indeed, it was about a month ago. We had a whole conference just based on updates in the science. But I'll try to give you an idea of where some of the really exciting innovations are, where we are going forward, and some things on the horizon. I'll primarily focus on those things that are out now that are changing our practice and changing the paradigm of how we care for these patients, as well as talking about, very briefly, some of our future directions. So these are my disclosures. Again, I will only be talking about the evidence-based portions of this. Another disclosure, I did go to Villanova. Sorry, Georgetown. So what is hypertrophic cardiomyopathy that we're talking about? So it's a very heterogeneous condition. It carries many faces. It affects many people. It's very ethnically diverse. It's very age diverse. It is the most common inherited cardiomyopathy. Some prevalent studies, if you look at the wall thickness as a diagnosis, which is actually a very crude way of diagnosing it, it's about 1 in 500 in the general population. If you look at genetic studies, genetic polymorphisms or variants that are considered likely pathogenic or pathogenic occur in as few as 1 in 150 to 1 in 200. So this is a very common condition. And yet looking at insurance claims data, we only diagnose this in about 1 in 3,000 patients. So that means that about 1 out of every 7 patients gets diagnosed, 6 out of every 7 patients gets missed. The more common type is obstructive. That's about a little over 2/3. And they have a few more treatment options, and that's one of the really exciting things that we get to talk about today. So this is just a graphic showing you how there's a big unmet need in recognizing this. Now, part of that is because a fair number of people with hypertrophic cardiomyopathy are asymptomatic or minimally symptomatic, or have their symptoms attributed to something else. Why is that potentially a problem? You're saying if someone's asymptomatic, why do we need to know that they have this? Sometimes, unfortunately, the first manifestation is catastrophic. It's sudden cardiac death. And because this isn't a potentially inherited condition, it's important to know that cascade screening and looking for it in family members becomes an important consideration, talking about things like family planning, genetics counseling, etc. One of the interesting things about it that I did want to mention is that just because someone is in their late 80s, early 90s, doesn't mean that this cannot be a first diagnosis of hypertrophic cardiomyopathy. When we do family screening, hypertrophy can occur at any decade of life. So just because someone has had negative screening through their 20s, 30s, 40s, and 50s doesn't mean that in their 60s and 70s, potentially even 80s, they cannot manifest hypertrophic cardiomyopathy as a first sign of their syndrome. So what are we talking about from a genetic basis? Well, we're primarily talking about gene variants that occur in proteins that are in the muscle fibril, in the myofibril. And so looking at them, we have our thick filament mutations, and these are the most common things like our myosin variants, especially MYBPC3 and MYH7 genes account for the majority of our genetic variants and our pathogenic variants. But then our thin filament mutations have their own sort of baggage and morphofunctional phenotype that's a little bit different. And this can actually affect prognosis, although it's not as clearly codified in the way that we make treatment decisions. But we do know that the thin filament and the thick filament mutations actually do behave differently. And this becomes really exciting for some of the future road ahead. So this is what it looks like at a visit with me. We talk about all these different things. We perform these different things. I touch on domains of symptoms. I touch on domains of family and genetics. I touch on domains of sudden cardiac death, risk stratification, and it's often a long visit. That's good because I'm a talker, and the patients tolerate me. So what are some of the challenges to correct diagnosis? Why may it be challenging to come to the right diagnosis? Well, there are common things that may mimic this. There are people with systemic arterial hypertension, especially uncontrolled hypertension, who have hypertensive heart disease that may manifest as asymmetric left ventricular hypertrophy rather than concentric. This is usually in combination with other features, other cardiometabolic abnormalities, especially chronic kidney disease. There are those patients who have valvular aortic stenosis, and that can cause asymmetric hypertrophy, but shouldn't cause any sort of subvalvular obstruction. There are patients who have physiologic myocyte hypertrophy from athletic training. This is usually resistance training more than endurance training, but sometimes that can be challenging, and this is where some of our novel imaging techniques, especially MRI or strain echocardiography, can be helpful in sort of parsing that out. And then there are these rare phenocopies or other conditions that mimic it. We won't harp on these too much. When I asked one of my former mentors about treating these, he said, you want to be an HCMologist, not an LVHologist. So I don't treat too many of these, but I do actually have not quite 10 of these patients in my clinic at this point, but close enough. So these are unique, but they occur, some of these things like the glycogen storage diseases occur at very rare prevalences in the population, only about 1 in 200,000 to 1 in 350,000. So looking at it, right, these are some of the, I might call them faces, but you might say, what's this guy talking about? These are the hearts. So these are the hearts of hypertrophic cardiomyopathy, but it carries many different morphologies. Sometimes you might have isolated basal septal hypertrophy in the top. You might have this reverse septal curvature. You might have the apical form. You might have diffuse hypertrophy that's asymmetrically increased in the septum, mid-obstructive variant with an apical aneurysm, or you might have something that's other. And it can carry a lot of different forms, and that's why it can be challenging based on traditional 2D echocardiography techniques to actually diagnose this. I just had a patient today who had several echocardiogram studies with a local private cardiology group, and they kept saying that he had mild hypertrophy until he got a really focused exam with a team that was much more in tune with potential hypertrophic cardiomyopathy, and his septum is 2.2 centimeters in thickness, so not mildly hypertrophied at all. And this is definitely out there, so I would say keep an eye on it. These are some of the patients I treat. This person here was actually a young person that is another Villanova alumnus. Young, healthy runner, but with a pathogenic variant and just followed routinely. This patient here is someone of West African heritage and is being referred to me for consideration of ICD therapies and even potentially advanced heart failure considerations. But we can see things like an apical wall motion abnormality and massive left ventricular hypertrophy more than 30 millimeters in thickness. This is another patient I follow in the on the right of your screen. This is someone with one of those thin filament mutations where they tend to have a lot more fibrosis and dilatation of the cavity. They develop some systolic dysfunction rather than having as much overt hypercontractility. And you can see extensive fibrosis here. And actually one of our fellows, Manav, helped to write up this case because this patient also has non-ischemic fibrofatty replacement of scar, which is very interesting. Here's another patient who owns a garage in the area from Afro-Caribbean heritage, has extensive fibrosis and is completely asymptomatic, but also has other high-risk features for sudden cardiac death. Again, the manifestations of it are sometimes first really catastrophic, where people just die suddenly and out of the blue. And so that's one of the reasons why getting a comprehensive evaluation helps to inform people on their treatment decisions and potentially save lives with primary prevention defibrillator use. Our positive predictive value is not great. Our negative predictive value is great. And so that we have a lot of shared decision-making, hence a lot of why my appointments are a little bit longer. Thinking about things that affect obstruction. Yeah, everyone knows a lot about how this is a preload dependent condition, how you want to affect heart rate, but even thinking about things like fasting versus meals. If you have patients who have eaten a meal, they actually have more obstruction. You divert blood to the splanchnic vascular bed, and you have less blood coming back to the heart. The same thing will happen in a very hot environment versus a cold environment. So it's important to, when we're talking with our patients, to know what are those things that affect the hemodynamics. Um, uh, and here are some of the things that we do from a drug management. Classically, we've got our beta blockers, which again have a lot of collateral systemic issues that go along with them. Issues of potential mood changes, issues of orthostatic changes, bradycardia, erectile dysfunction, decreased libido, lots of different things that you could think about. Yet they do improve some things with hypertrophic cardiomyopathy, so we still use them. The calcium channel blocker is very similar, but often have more of a blood pressure effect from vasodilatation. Disopyramide is a bit more historic in our use. It still has a potential place, but it's not something that we turn to a lot, and we've even had a lot of supply chain issues with it. Some patients can't even find it if they go to 4 or 5 or 6 pharmacies, and it has to be dosed multiple times a day because our extended release formulation is just not available, just troubles with the supply chain. So how about thinking about those things that we do for these different phenotypes, about the 30% who are non-obstructive or the 70% who are obstructive? Well, just a few years ago when we had an update in our national guidelines, these were sort of the things that we were thinking about. And obviously there are subtleties and personal changes to each patient who comes in with this, but this is primarily what we're looking at. And if you think about what's the data behind these things for non-obstructive hypertrophic cardiomyopathy, there's very little. This is a data-free zone. We really don't have a lot in the way of randomized controlled trials. They're very few and they're very small, and they're often with more second or third line agents, things like ranolazine, et cetera. But this is a data-free zone in many ways. The obstructive hypertrophic cardiomyopathy space, we have a lot more historic options, and there's a great history in the area of treating these patients. But our data behind it has actually been a bit poor as far as how solid it is. It's been more of a treatment of tradition rather than a treatment based out of evidence. And so that's one of the exciting things going forward, is how that landscape is changing these days. So this is a patient of mine. This is a patient who's a middle-aged woman who ended up having basically paralyzing symptoms from hypertrophic cardiomyopathy. This is a parasternal view of the heart where we see the inflow through the mitral leaflets, the outflow here, the aortic valve here. You can see that there's systolic anterior motion of the mitral leaflets, and indeed even septal contact of the anterior mitral leaflet. These leaflets are elongated, and that's often a morphofunctional feature of hypertrophic cardiomyopathy that contributes to obstruction. And she had, I did a TEE on her because she was referred to us first for considerations of mitral valve disease. They didn't know that she had HCM, and when I sedated her, she really dropped down her pressures. And I put a stethoscope on her chest and we flooded her with fluid, and she did okay after that. But then later we got her to septal myectomy, and this is what she looked like afterward. You can see that there's still a little bit of some systolic anterior motion of the mitral tip right here. However, the left ventricular outflow tract is relatively unobstructed at this point. And when we look again at her preoperative echocardiogram, we can see how there's not too much real estate in here, especially with severe mid-cavity hypertrophy versus her postoperative echocardiogram that shows that flow of blood is a lot less obstructed, and indeed even her mitral regurgitation looks a lot better. These were her preoperative gradients, which are probably underestimated on this echo picture, and then her postoperative gradients, which are normal, flow is normal out of the heart. So how are we changing the landscape? Surgery has been a hallmark of our treatment, since the late 1960s, just up the road with Drs. Brownwald and Dr. Morrow. And the traditional Morrow procedure of a basal septal myectomy has been, was a really happy accident in treating this years ago, but we've been doing a lot of that with some changes for many years, and yet that doesn't actually modify the disease condition, just modifies the hemodynamics in many ways. So how are we entering a new era? Well, interestingly, patients have a lot more options from the pharmacologic standpoint that may actually get to more of the molecular underpinnings of what's happening and trying to prevent some of those complications. So this is a timeline of advances in hypertrophic cardiomyopathy care. You'll see a lot of names that were in the NIH and Bethesda area. Even Bering, who was here at Georgetown as well. But then looking at the randomized controlled trials, you can see how it's very light. We didn't have a whole lot in the way of randomized controlled trials for treatment of hypertrophic cardiomyopathy, and thankfully that landscape is changing, and that's one of the reasons why it's a much more hopeful time for patients to be getting care with hypertrophic cardiomyopathy. So even though we've been using beta blockers for about 6 decades with hypertrophic cardiomyopathy, we didn't actually have a good randomized controlled trial for it until even a small study. And this, you can even look, 29 patients in Denmark, and they were randomized to double-blinded crossover trial looking at the effects of metoprolol. And what they found was that it helped people to feel better, but it didn't help them to do any additional exercise. And so their dyspnea improved, their angina improved, and their KCCQ was not markedly different, although most of the trends were towards a higher score on their Kansas City Cardiomyopathy Questionnaire for Quality of Life. And yet, when we looked at the exercise metrics, it didn't improve peak VO2 max on cardiopulmonary exercise testing, and it didn't actually change the post-exercise pulmonary capillary wedge pressure, so that it's not necessarily having as good a hemodynamic effect as we would hope that it has. And because beta blockers are drugs that have systemic collateral effects on beta receptors all over the body or effects on the peripheral circulation, that's one of the reasons why they do have an Achilles heel in treatment, and some patients just can't tolerate them. Someone I saw earlier today who's young and healthy, ex-military, ex-marathoner, ex-Ironman athlete, was put on a low dose of metoprolol and just felt dismal, felt worse being on the active treatment than he was on no treatment. So thinking about some other things, now that we're talking about exercise and hypertrophic cardiomyopathy, that's been another big change recently. In the past, we've been guilty of telling these patients don't do anything. Some patients have even been told in years past, don't even climb up a staircase. And you can imagine how devastating that is psychologically to them, especially if they're someone who's used to having an active lifestyle. And some of the patients, thankfully, didn't pay attention to us. And some of them, unfortunately, did. And some of them ended up developing cardiometabolic conditions because they didn't lead a healthy lifestyle with regular physical activity and all the benefits that they get from that. So this was a multi-center trial primarily at hypertrophic cardiomyopathy centers, where patients were enrolled and given, they were given different forms to fill out about how much activity that they're doing. So you can imagine what the limitations are with self-reporting. However, when they looked at patient reports of how much activity that they were doing and also looked at what their hypertrophic cardiomyopathy specialists were recommending that they do, some were doing even a lot more than they were recommended to do. And that was interesting. And when we looked at the safety of that, what we ended up seeing was that there was no signal of harm in patients who were engaged in vigorous activity compared to those who were not. And so what that tells us is that this old traditional knowledge that, or I should say, teaching that exercise can be very dangerous for the patient with hypertrophic cardiomyopathy is being wiped away slowly with more data showing how the safety of exercise can even be applied to a lot of patients with hypertrophic cardiomyopathy. Oh, I just had a thought and I lost it. In addition, we've also had studies recently looking at high-level athletes and showing that even if they have a primary prevention ICD, that their rates of shocks with vigorous activity, competitive sports, NCAA, professional athletics, are not higher than the population who doesn't participate in those high-level activities. And so we're learning a lot about the safety of them. If you think about it, patients who experience an exercise-related or exercise-associated sudden cardiac death make the headlines. And so there's a big reporting bias there versus someone who dies while making a grilled cheese sandwich, or someone who dies in their sleep. That's not going to necessarily get a lot of headlines. Maybe the grilled cheese might. But you can see how in the past, this voluntary reporting, when you've looked at the headlines, that's one of the reasons why there has been this misconception that activity can be very dangerous. And why hypertrophic cardiomyopathy was thought to be the #1 cause why young people have sudden cardiac arrest with athletic endeavors. But that again is probably a big reporting and referral bias. And so that was exciting news for our patients. And many of them that I see in clinic are interested in doing lots of activity and leading a healthy lifestyle. And it's about finding a plan that's appropriate to them, that's appropriate to their symptoms, to make sure that they're doing it under safe parameters. And safe doesn't mean the absence of risk, but safe means understanding what are the risks, how much are they willing to accept, and how much would they like to do, and how can we make sure that those risks are lowered. If we're talking about a young athlete and we're talking about all the stakeholders, you think about the team, the team trainer, the team physician, the coaches, the teammates, the institution, right? It's about getting a lot of the interested stakeholders at the table and talking through this. And then we even think about the risks of not continuing to participate in high-level activities. And for some people, that can be really devastating from a mental health perspective. So one of the exciting things these days is we can often tell people, yes, do these activities, do them under these parameters, and you can do them safely. And that doesn't mean that they're totally risk-free, but it means that in many cases, they can continue to do the things that they love and be healthy. And that's an exciting prospect. So does anyone know what this flower is? Go ahead and shout it out. So this isn't the European variety, but this is one that's native to North America. This is Penstemon digitalis. Yeah, this is one of my favorites. So this is from my garden. I have a couple Penstemon species. That's one of my hobbies. But this is Penstemon digitalis. It produces a glycoside. So I put it here not because we're going to be talking about glycosides, but because it was a way of me saying that there's a new bloom of therapies for hypertrophic cardiomyopathy. And one of the most exciting drug classes are these cardiac myosin inhibitors. So what are these? These are designer drugs. These were specifically developed in a lab. These were designed at a pharmacology lab out in California. And actually, the two that are really under investigation now were actually developed in the same lab. But one group, the first one that was developed, mavacamten, was thought to be maybe not the optimal drug, and another group, so they sort of had a splitting where one group decided they wanted to continue to pursue putting that one to market and testing it, and the other group said, well, let's think about ways that we can change the design. And so that's how the second drug, aficamten, came out. So how do they work? They work at that sarcomeric level that we talked about. They affect myosin and actin cross-bridging. And myosin and actin are in a steady state of either being bound, or myosin can be in a super relaxed and unengaged state. And these molecules affect that balance by putting more of the myosin heads into a super relaxed state so that there's less hypercontractile force, which is often one of the molecular underpinnings at a tissue level of hypertrophic cardiomyopathy. This is not just a disease of thickening of the muscle, but this is also a condition of hypercontractility, of overvigorous contraction, and even under resting conditions because of too much myosin actin cross-bridging. So these are reversible agents. They're specific to the cardiac tissue. That's exciting because that means a lot less collateral systemic side effects. If you look at this top graphic, this is a picture of a lot of engaged myosin actin cross bridges, and then you add a cardiac myosin inhibitor, and you've inhibited some of these and put them into more of a super relaxed state. So this is a very potent negative inotropic agent. And it's a little bit counterintuitive to a lot of what we do in cardiology, where we try to actually support how vigorously the heart squeezes, but this is a bit of the opposite. So why is this a good thing for our patients with obstructive hypertrophic cardiomyopathy? Well, again, if some of the underpinnings are hypercontractility and there's dynamic obstruction, that is inefficient emptying. That means the heart, which is already more hungry or hungrier for energy, hungrier for oxygen than hearts of normal thickness and hearts of normal contractility, has to do extra myocardial work to generate the pressure and force to empty with each beat. So what these molecules do is they decrease contractility in order to reduce the dynamic obstruction, allowing the heart to empty more efficiently. That lowers the cardiac filling pressures. It lowers stress on the myocardium and improves its energetics. So this is a really exciting phase of what we're doing to treat patients with hypertrophic cardiomyopathy. This is the first in class, and it is an FDA-approved medication, mavacamten. It was approved in April of 2022, and it's approved in a very specific way, something called a REMS program, or risk evaluation and mitigation strategies. And so the way that patients get this is a little challenging, but I understand the safety monitoring behind it. So the pivotal trial was really this Explorer HCM trial. And we'll get to the Valor HCM trial a little bit more. The Pioneer HCM trial was more of a dose-finding trial that helped to inform a lot for the phase 3 trials. So what they really looked at with this is it was a short trial. They weren't looking at hard cardiac endpoints, and we don't have those with these medications. So we can't delude ourselves in thinking that we're making people live longer. And indeed, most people with hypertrophic cardiomyopathy have a normal life expectancy, and many of them die from something not called hypertrophic cardiomyopathy. That's a really powerful thing to tell people when you meet them. Now, that doesn't mean that that's all of them, but a lot of what we're moving here is quality of life and allowing people to live better, live healthier, and live with fewer symptoms. And that's a really noble goal, I think, is to find those who are suffering and help them to suffer less or suffer not at all. So looking at some of these things, quality of life metrics, et cetera, as well as objective measurements of functional capacity, we saw that patients in the mavacamten arm were more than twice as likely to achieve the primary endpoints, and that it was a potent reducer of left ventricular outflow tract obstruction, and that they had meaningful increases in their peak VO2 from baseline. So this was an exciting trial showing that, yes, it was beneficial for many patients. I'll note for many patients, but not all. And this is one of the frustrating things, is that even when we obliterate some of the gradients, some of the patients that I prescribed this, to whom I prescribed this medication, still have some functional limitations, still have some symptoms. And it's not a one size fits all, but that's usually the case with medicine. It's not as cut and dry as we'd like it to be. So again, looking at even post-exercise gradients, and exercise is often the best thing to provoke obstruction, rather than relying on things like Valsalva or stand maneuvers. But even the post-exercise gradients were below 50 millimeters of mercury, and so that falls into the range of just mild obstruction, even with exercise, and that's really exciting. This was the other part to keep in mind. Even though this is a potent negative inotrope, the mean change in left ventricular ejection fraction in the patients enrolled in this trial was about 4%. So although it's a potent negative inotrope, the EF was relatively unchanged. Why is that? The heart was emptying more efficiently. So when you allow it to empty more efficiently, the ejection fraction, which is really just it's just a ratio. It's not a physiologic number. It's just a ratio. But the ratio of how well the heart was emptying was relatively unchanged because it was emptying more efficiently. And so although we look at this as a safety endpoint, making sure that we don't decrease the ejection fraction of patients taking this medication, thankfully in the clinical trials, it's been a low occurrence. In the Explorer HCM trial, it was about 5%. And in a future trial that we'll talk about, it was even lower than that. Again, significant reductions in left ventricular outflow tract gradients at rest and with Valsalva. And if you look at quality of life on the KCCQ questionnaire, if you look at some of these other pivotal trials, for example, how often do we use sacubitril valsartan for systolic heart failure? We use it like crazy, and yet it had really no meaningful impact on quality of life in their KCCQ questionnaires. And these patients feel, many patients feel a lot better with mavacamten if they have obstructive hypertrophic cardiomyopathy. And I should say that this is primarily for the form of left ventricular outflow tract obstruction. The mid-cavity obstruction group was not included in this study, but it's being studied in the future. That's a little teaser. So again, indications for use are primarily for left ventricular outflow tract obstruction, those with class 2 and class 3 symptoms, and that's how it's labeled. It was studied in patients with class 3 and 4 symptoms, and it was beneficial in that. That's called the VALOR HCM study that we'll talk about in a short time. But this is a shared responsibility of taking this medication. The FDA set rules that we have to follow, just like basketball has rules. This is that we have rules that we have to follow, and I think they're good for safety because we want to make sure that we're using the drug both safely and effectively. So there's a shared responsibility between the prescribers who have to go through a program where they learn a little bit about prescribing it. It's open to many cardiologists, but again, knowing some of the nuances is important before you use this drug a lot more freely. Unfortunately, it does have a lot of drug-drug interactions, especially with isozymes in the cytochrome 3A4 and 2C19 metabolic pathways. So you do have to be careful with some other medications that people commonly take, proton pump inhibitors, some antifungals, antiviral medications, some antibiotics, et cetera, et cetera. So when we look at the echo findings, we saw a lot of surrogate markers that were promising. Again, decreased gradients, improvements in diastolic function, improvements in left atrial volume index and size. And the same thing was seen in the cardiac MRI substudy. So we actually saw a regression in overall myocardial mass. It's not that it's targeting the thickened portions of the heart, but all over where there's increased myocardial mass, as you decrease left ventricular filling pressures, you decrease some of the driving force for additional pathologic hypertrophy of the myocytes. And so as left ventricular pressure overload is improved by relief of obstruction, you have an overall reduction in cardiac mass. And that's an exciting change. Now, there are a lot of unknowns with these medications. We've only been using them for a short time. And so long-term safety is still something that we're thinking about and looking at. We don't know what effects they might have on things like atrial function because there is myosin and actin in the atria as well. And there are some early studies that are, I think, pre-publication talking about reductions in left atrial strain function. We don't know of any increased signal for things like atrial tachyarrhythmias, but there's a lot more that we're learning about them. And so for the time being, again, we're using them cautiously, but we're using them hopefully into some patients with great success. This was a patient of mine that I inherited. He is a middle-aged man. He works in IT and communications. He was a master scuba diver, and he could not rake his leaves in his yard without having to rest for a full day afterward because he was just wiped out. And you can see that his left ventricular outflow tract gradient was extremely high, over 5 meters per second for the max velocity, or translation in millimeters of mercury, over 100 millimeters of mercury for obstruction. So he was desperate for something that would help his quality of life. He's not in the best of shape because he had to reduce how much physical activity he's doing, and he has a lot of central obesity. But we talked about this last summer when I had him back for a follow-up visit, and he decided he wanted to try this medication. This is what he looks like this day. His ejection fraction is still about 65%, and his left ventricular outflow tract gradient with Valsalva maneuver is probably the same as mine. So he really has obliterated his left ventricular outflow tract gradient, and I just happened to run into him in the hospital because his wife was unfortunately hospitalized and under the cardiology service. And he showed me a picture of a kayak. And he said, "Doc, I should have told you about this. I bought one of these and you're to blame. I am rowing it around a 56-acre lake and I feel fine." And that's pretty awesome. So exciting times. Um, so how about patients who have more severe symptomatic limitations? Well, this was a study in patients who were referred to hypertrophic cardiomyopathy centers for septal reduction therapy. They were referred for consideration of alcohol septal ablation or surgical septal myectomy. And they were randomized to either placebo or mavacamten in a double-blind fashion, initially for 16 weeks, and then after 16 weeks, they were allowed to cross over to get the active cardiac myosin inhibitor and see what changes they might have had. When we looked at this, what we found was that after the initial 16 weeks, more than 70% of patients who were initially eligible and referred for considerations of septal reduction therapy um, were no longer guideline eligible for that. Where was that? Yeah, so only 18% remained guideline eligible for septal reduction therapy because of improvements in their left ventricular outflow tract gradients. And I'll point out that these were patients who were on maximally tolerated therapy, including triple therapy with beta blockers, calcium channel blockers, and disopyramide. And so they were really on heavy hitter medications as additional negative inotropes and as additional therapies to relieve obstruction. So when you added it to this population that was very limited and already on a lot of therapies, many of them improved a functional class. More than 60% improved one functional class and about a quarter improved two functional classes versus the placebo group. And where you can see that probably with referral to a hypertrophic cardiomyopathy center and talking about different ways that they could change their treatment, there may be some colliding factors here that's why they improved the functional class with time, but there was a big difference, of more than 40% difference in relative difference in the patients who were able to improve at least one functional class, and a very large difference in the patients able to improve two functional classes. So this was exciting because what this told us was that even for those patients with severe symptomatic limitations in whom we were thinking of more invasive therapies, and invasive therapies are often limited geographically to a small number of hypertrophic cardiomyopathy centers. So it's not widespread, it's not as widespread, widely available for many patients for access unless they're able to travel and get to these centers. So this looks like a potentially viable option for patients to be on in order to consider medical therapy before they go to something more invasive that may have irreversible side effects or come with a little bit more recovery in the sense of post-procedural morbidity. So even going out to over a year at this point, and that's the last data set that was published this summer, when they looked at 56 weeks of follow-up, they saw that there were sustained results of improvement in functional classes, and that patients, many of the patients who were given the mavacamten medication decided not to pursue septal reduction therapy, even though it was always available to them if they chose to stop the therapy and go for the procedure. Only about 10 to 11% actually elected to undergo septal reduction therapy after getting the active treatment. And I think that speaks a lot to patient preference of what they'd like to do and what therapies they'd like to pursue, an invasive versus a non-invasive. So this is a good initial option. This does not replace septal reduction therapy for those patients in whom it is most appropriate, or patients who are really non-responders to mavacamten with regard to quality of life, because again, we know it's not perfect, and only about 60 to 70% of patients had a really positive result to mavacamten in our clinical trials. And in a real life experience, that's about accurate. We use it a little bit differently in real life than we did in the trials, I think. And that's been the consensus at our recent HCM sessions in Cleveland last month. But again, not everyone has the same benefit that we hope for them. Any questions on mavacamten so far? Yeah, it's an exciting medication. But again, it's nice that we have a buffet of options. When I get a patient that comes before me and they have obstructive hypertrophic cardiomyopathy and they're on their background beta blockers or calcium channel blockers or both, and we're talking about different treatment options, I present them with this little buffet, and I talk about things like disopyramide as a next step agent, with all the challenges that we may have with it. But for some people, it is still very beneficial, and it allows them to live with many fewer symptoms, especially if they have potential access issues for mavacamten, or other considerations why they wouldn't want to take that at this time. I talk to them about septal reduction therapy. I talk about how patient selection is really important for figuring out alcohol septal ablation candidates versus septal myectomy candidates. I talk about the success rates, where septal myectomy has the highest success rate at about 95% with experienced surgeons. But again, it comes with those upfront costs of um, the surgery, the recovery, and not necessarily changing the underlying disease condition, but just changing the flow dynamics. Yeah,
A
okay.
couple questions for mavacamten. What's the rate of complication when you overshoot and then you end up with somebody with a reduced ejection fraction or cardiomyopathy where
Yeah.
they kind of lose too much of the max side? And two, what is the usual thought process of how long are they going to be on this therapy? Are they going to be on it for life? Are they going to be on it until a certain event? Or?
Okay. So I'll answer them in reverse order. So it is a long-term medication. It doesn't actually change the predisposition for having hypertrophic cardiomyopathy and obstruction, because it is a reversible medication. When you let it wear off, the effects wear off. That also plays into the reduced left ventricular ejection fraction that you can see in a small number of patients. In the Valor HCM trial, they saw it in about 3.5% of patients. In Explorer HCM, they saw it in 5.6, I think, percent of patients. But they were also a little bit more careful in their dosing with patients in Valor HCM. When you stop the medication, left ventricular ejection fraction really comes back to normal. So there aren't irreversible changes. It's just the fact that you are affecting actin-myosin cross-bridging. And that's why you have a temporary reduction in left ventricular systolic function. There are things that affect this. Severe systemic illness, right? It's almost like a two-hit. So if you have someone that might have a SIRS response, sepsis, bacteremia, acute hospitalization for different issues. Having that stressor on top of taking mavacamten seems to be something that predisposes people. And the most common thing from a shared experience with HCM centers when we talked about this last month was patients going into atrial fibrillation for a variety of reasons will often temporarily drop their left ventricular ejection fraction. And once you improve the cardiac, the cycle length variation and the changes in loading conditions get them back to sinus rhythm, often they're able to resume the mavacamten after a temporary cessation. It's very rare for patients to be in big trouble with reduction in ejection fraction. In the Explorer HCM group, 4 out of 7 patients were not actually symptomatic to any degree with anything that might be construed as congestive heart failure symptoms. And the reason is their heart was emptying more efficiently, even if the ejection fraction was mildly reduced. One of my mentors at Pittsburgh had a patient who was one of those patients. He was taking mavacamten, felt great, dropped 60 pounds from increased exercise and improvements in lifestyle, and was probably taking more mavacamten than his body size now needed. And when his ejection fraction was 45%, and had no idea it was until he came in for one of those surveillance echocardiograms. So this is, it's one of those things we want to avoid it because this is a big safety concern. And that's one of the reasons why the REMS program and active surveillance with echocardiograms at certain intervals is really important. Great questions. Yeah, Myrna.
Do you see that or people say, well, you do infection or thoroughly.
Yeah, that's a great question.
Maybe just repeat it for the people that are on.
Yeah, so is there a use of mavacamten in patients who are acutely ill with left ventricular outflow tract obstruction? At the moment, no, and probably not in the future either, for 2 reasons. Number one, it's only available through the REMS program as an outpatient prescription. It's not on inpatient formularies. Secondly, it has a very long half-life and a slow onset. So unfortunately, it's not a bailout plan. Our bailout plans are few and far between. That's one of the reasons why disopyramide is still a little bit in the conversation, is because it can be an acute bailout plan in the right cases. But again, at best, sometimes 60% of those people with really refractory obstruction, despite other medical therapy, other changes that you're trying to affect in their hemodynamics, may respond to disopyramide. So even that's not the perfect option. But no, this is unfortunately not an acute bailout plan. The second-in-class myosin inhibitor that we're talking about, aficamten, has a shorter onset of action. The pharmacologic, the half-life is about 3.4 days, so it's still not really rapid onset, but it is quicker. Mavacamten, we check echocardiograms at 4, 8, and 12 weeks. That's what was set out in the negotiations between the FDA and the Explorer HCM board when they talked about FDA approval. That's not a hard and fast science. It's really just sort of looking at approximately these time points for when patients would be reaching certain milestones, systemically getting mavacamten. Where would we look at for both safety and efficacy, looking at the LVOT gradients and thinking about dose changes for the future and looking at the ejection fraction for safety. So how about some of the future stuff? So I won't go too in depth in this, and there's so much here that this could be a whole talk on its own, but I wanted to at least give you an appetizer to talk about some of these things. So we are still a site for aficamten in the Sequoia HCM trial. We're at end of study. That just happened at the end of last month. We're really looking at the data in December. That's when the database is being locked, and we should have results in early 2024. But we're very hopeful that this will be a medication that is also available to patients that has fewer drug-drug interactions, but acts in a very similar way. Again, it was developed in the same lab, basically by a same group of investigational pharmacists and basic scientists. But this is not yet FDA approved, not yet commercially available, and still investigational. There is a rollover of these patients into a long-term or open label extension arm called Forest HCM. In case you're wondering and you're a bit of a tree hugger like me, it's a California company, hence why they have Redwood and Sequoia. And there's another study called Maple, which is ongoing, that's looking at randomizing patients either to metoprolol or aficamten as a first-line agent. So seeing if the CMIs may actually be a good initial agent to try versus our usual class 1 recommendations, such as beta blockers, which are in the guidelines, but again, have a real paucity of hard data to support their use and don't actually help people exercise more. So this is an exciting horizon for hypertrophic cardiomyopathy care, but still investigation. So again, this was a 6-month trial where we had randomization, 1 month roll-in, and then a 1 month washout before end of study. And then the Redwood HCM cohort that came before this was interesting because that looked at some patients who were on disopyramide. And then the cohort 4 from the Redwood HCM also looked at non-obstructive HCM patients, and that's a really exciting thing. So when Marty Marin presented this data at HFSA in 2021, we talked a lot about cohort 1 and 2, and they saw, again, no significant reductions in left ventricular ejection fraction. On average, it dropped a few percentage points. But they saw marked improvements in left ventricular outflow gradients and improvements in KCCQ questionnaires in the active treatment arm. So that brings me a little bit to this, again, some of these other future directions. There was a phase 2 dose finding study called Maverick HCM, which looked at pharmacokinetic drug levels and was really a dose finding study for this larger phase 3 trial with mavacamten called Odyssey HCM. And it showed that there were significant reductions in biomarkers, but it wasn't powered for endpoints. And interestingly, in the long-term extension arm of this trial called MAVA LTE, we actually saw that up to 27% of patients experienced a reduction in left ventricular ejection fraction less than 50% at some point. So this is a different population. This 30% of patients with non-obstructive HCM is a more challenging population. Again, that's been really desperate for therapies that are available to them, but because this can improve some of the lusitropy of the heart, it can improve some of the relaxation properties, we hope, we think it's good enough to try in these larger phase 3 trials. Aficamten is also being studied in Acacia HCM, again, another tree. So people are always asking, which tree is it again? They just started enrollment for Acacia. Only 2 sites are up and running. We'll be one of them in the future. Once our paperwork goes through Odyssey HCM, we are an active site for that. We'll be enrolling for patients, and enrollment is about halfway through. Enrollment is going a lot faster than people expected it would be. So a lot of people are very excited about the prospect of this treatment to treat patients who have had some devastating symptoms, especially things like angina or exercise intolerance because of problems with cardiac energetics and hypercontractile function, supply-demand mismatch, especially in the hypertrophied segments, even in the absence of obstruction. A paper by James Moon and the University College London group recently showed that 100% of patients with the apical variant of hypertrophic cardiomyopathy have perfusion defects on stress cardiac MRI. And so all of these patients are living with, and that probably is maybe a sine qua non of apical hypertrophic cardiomyopathy. And that's one of these underpinnings that we have to change in order to change the natural history. In the past, apical hypertrophic cardiomyopathy was quoted to patients as being, oh, you have the good kind. You have the kind that you want to have. I don't think anyone wants to have it. And a lot of patients really suffer with it because we don't have targeted therapies for it. So many patients that we see are very hopeful for targeted therapies. And in the meantime, we're still trying a lot of other things that are in our armamentarium, things like ranolazine, SGLT2 inhibitors, aldosterone receptor antagonists, but again, things that are just thought to be good, but are not known to be good. And many of these patients have only partial relief of symptoms. So it's a challenging thing. There's a really exciting horizon with gene therapy. The week of our hypertrophic cardiomyopathy sessions, the Cleveland Clinic performed the first in-human gene therapy, where they delivered a normal copy of MYBPC3 to a young patient who had non-obstructive HCM. And what this is it's an attenuated adenovirus vector that obviously hijacks our cells' machinery and then produces normal copies of the myosin gene, which are then available for the patient. Because you have one normal copy of myosin and one pathogenic variant, and if we tip the scale so that there's more expression of the normal copy, that should be helpful in trying to reverse really the true underpinnings of what this condition stems from in those who have a pathogenic variant. Unfortunately, we can only identify pathogenic variants on average in about 30 to 40% of all comers with hypertrophic cardiomyopathy. If you have true familial hypertrophic cardiomyopathy, our diagnostic yield is about 50 to 60%, but it's still not perfect. But this is, again, trying to personalize care and look at the patient in front of you and looking at the underlying cause and thinking about what are some of these really exciting advances in science where we can potentially change the natural history and offer something unique and personal to an individual that helps with their, something that they were born with, that they don't have a say in whether or not they've developed this or not. So very exciting stuff. So other small things. So I mentioned SGLT2 inhibitors very briefly. There are a few trials ongoing. One of the big ones is this EMPA repair study. There's a really early phase 1 study of this molecule from Edgewise Pharmacologics called EDG 7500, which is called a sarcomere modulator, and it primarily has more effects on lusitropy in the heart, relaxation, rather than effects on negative inotropy. And so it's really exciting as a potential therapy for those patients who have much more in the way of diastolic dysfunction, and even for patients who have pure diastolic dysfunction with HFpEF, not just hypertrophic cardiomyopathy. So we'll see how that pans out. The science has to happen first before we can really sing its praises. And then there are several studies ongoing with molecules that affect cardioenergetics or metabolism in the heart, changing the availability of ATP, et cetera. And one of them is with this substance, perhexylene, in one of the coolest names, the metal HCM study. All right. So I hope I've at least given you an idea of how our landscape and treatment choices have changed, especially for those patients with obstructive hypertrophic cardiomyopathy, and how we are now entering an era of randomized controlled trials and more solid data when it comes to picking treatment options for them, how we're trying to personalize this onto the individual based on the unique form that they have, the unique hemodynamics they have, their lifestyle considerations, their genetics, and what their wishes are and what their goals are, and how shared decision-making can give us a much more personalized care pathway than it has before. You know, this has been a really exciting new chapter to my early career, and I couldn't do it without really the village of people around me, people in my past, like my mentors, my dad, who's a cardiologist, my wife, who's so supportive, my cousin, who's a cardiologist in Germany and has hypertrophic cardiomyopathy, all the people here in the MedStar family, the imaging departments, my co-faculty who help teach me every day and every week, our research team, our genetic counselor, my nurse, and everyone who's helped to support this ongoing endeavor, and really, at the end of the day, helps patients feel better.